All right. Hello, everyone. Welcome to Stanford Care's monthly community health talk series. My name is Joey. I'm a second-year medical student here at Stanford. And I'll be serving as the moderator for tonight's talk. I'm pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. I'm very pleased to welcome Dr. Robert Huang, who will speak on hidden burdens, understanding digestive cancer risk in Asian populations. Asian Americans are often perceived as a healthy minority group, yet data show they face disproportionate risks of digestive cancers and chronic conditions, including certain esophageal cancers, liver cancer linked to hepatitis B, and gastric cancer. In this talk, Dr. Huang will explore why these disparities exist, the barriers to early detection and treatment, and what communities and healthcare systems can do to address them. Dr. Robert Huang is a gastroenterologist and clinical researcher who seeks to improve the prevention, diagnosis, and therapy of digestive malignancies. His clinical practice is focused on the use of endoscopy to improve digestive cancer detection and prevention. He has a particular interest in gastric precancerous lesions, such as atrophic gastritis and intestinal metaplasia, which give rise to stomach cancer. His research is aimed at improving digestive cancer outcomes and reducing cancer disparities through data science, cohort building, and biomarker development. His research group conducts patient-facing research studies, EHR-based studies, and large database studies. He has also participated in activities at the local, regional, and national level to improve the health of Asian Americans. Thank you, Dr. Huang, for your time tonight. Please take it away.
Thank you very much, Joey, for that very kind introduction. Welcome all. Thank you for attending. These series are usually well attended, and it's such a pleasure to be here tonight to talk about a topic that is so important to all of us, cancer, specifically digestive cancers. I'm a gastroenterologist, as Joey said. My clinical practice is focused on endoscopy and means and mechanisms to enhance early detection and prevention of digestive cancers. And our group also conducts patient-facing research to try to address questions in prevention, biomarker development, and other strategies to reduce the burden of digestive cancers. So tonight I am going to talk to you about Asians and digestive cancers. If you'll just give me a moment to pull up my PowerPoint. The title of this talk is Hidden Burdens, Understanding Cancer and Chronic Disease Risk in Asian Populations. So in this talk, I want to do a couple of things. I wanted to first talk about epidemiology and review the burden of digestive cancers among Asian Americans. The majority of this talk is actually then going to be spent on what gives rise to these differences. And a couple of things in particular we'll be talking about are immigration patterns and nativity status, the role of environment, specifically diet and pathogens on cancer risk, and the very interesting interaction between genetics and environment, specifically among Asian Americans, which increase the risk for digestive cancers. Finally, in the last third of the talk, I'm going to talk about prevention. With the knowledge that we achieve from the first part of this talk, what mechanisms can we implement to reduce the burden of digestive cancer among Asian Americans? So briefly, what is the burden of digestive cancer among Asian Americans? This is data from NCHS, or the National Center for Health Statistics. Every year, NCHS publishes mortality data. So everybody who dies in the United States, these death records then get collated and collected and allows for nationwide statistical analysis. So the figure on the left here shows the percentage of all cancer deaths due to just the top 4 digestive cancers, so colorectal, liver, gastric, and pancreatic, by racial group. And so the first column shows whites, non-Hispanic whites. And then the other columns show different Asian subgroups: Koreans, Japanese, Vietnamese, Chinese, Filipino, and Asian Indians. So you'll see that almost every Asian subgroup has a higher fraction of cancer deaths due to digestive cancer than non-Hispanic whites. When you look at it by specific cancer type on the right, you'll see that for each of these four major cancers, Asians have a higher fraction of cancer death, colorectal, liver, gastric, and pancreas. Esophagus, which we didn't include in this figure, is an interesting story. So Asians are at significantly increased risk for a certain type of esophagus cancer called squamous cell cancer, or SCC, whereas they are at a lower risk for esophagus adenocarcinomas. So if you look at esophagus cancer in aggregate, it doesn't show that Asians are at increased risk. However, Asians are at significantly increased risk for a certain type of esophagus cancer. Here, I wanted to spend a moment to talk about the importance of disaggregation in public health research. Asian Americans refer to a very diverse and heterogeneous group of Americans, and understanding differences and nuances between these groups can inform public health research. So here on the left, I wanted to show gastric cancer incidence in the United States. This is data taken from SEER, or the Surveillance Epidemiology and End Results database. And so you can see that when you disaggregate Asians, that there are different patterns of gastric cancer incidence. So all Asians have a higher incidence of gastric cancer compared to non-Hispanic whites. That's the black line on the bottom. But certain Asian groups, such as Korean Americans and Japanese Americans, appear to be at particularly high risk. Here, the figure on the right shows liver cancer deaths, liver cancer mortality in the United States derived from NCHS. And this shows this temporally over a 15-year time period from 2003 to 2017, and also disaggregated by race. So you'll see that there is one particular subgroup here that has a high rate of mortality from liver cancer, but also notably their rate of mortality has increased over time, and that is Vietnamese Americans. And if you just aggregated all Asians together, you wouldn't necessarily have seen this pattern. So whenever possible, disaggregation of cancer statistics by race can help to inform public health prevention measures. So the first topic I want to talk about is immigration. How do Asians living in the United States, how does their burden of cancer differ from the burden of cancer among non-Hispanic whites, as well as nationals from their native country? So I wanted to tell the story of two cancers here. And so here we're going to look at proportion of cancer mortality. So that is the percentage of all cancer deaths caused by a given cancer. So the first cancer we're going to look at, and the first country we're going to look at, is Vietnam. If you remember from the prior slide, Vietnamese Americans, there's something a little bit different among Vietnamese Americans. They have the highest rate of liver cancer, and this rate seems to be actually increasing over time. So in Vietnam, liver cancers are responsible for 22% of all cancer deaths. It's really a tremendous statistic if you think about it. That means liver cancer deaths are 1/4 of all cancers. That includes lung cancer, all of the other digestive cancers, prostate cancer, breast cancer. So this is a major public health problem in Vietnam. But what about when Vietnamese immigrate to the United States? What is the proportional cancer mortality of Vietnamese Americans? So the answer is 16%. So it's a little bit lower than in Vietnam, but still much, much higher than the proportional cancer mortality among non-Hispanic whites in the United States, 2%. So for the cancer mortality burden of liver cancer is somewhere in between non-Hispanic whites and Vietnamese. So then the other cancer I wanted to look at, and the other country I wanted to look at, is stomach cancer in South Korea. As some of you may know, stomach cancer is a major problem in South Korea. 17% of all cancer deaths in that country are due to stomach cancer. And what is it like in the United States? And what about Korean Americans? So Korean Americans, 13% of all cancer deaths are due to stomach cancer compared to 2% in non-Hispanic whites. So it seems that Korean Americans and Vietnamese Americans, their cancer mortality burden is somewhere in between that of non-Hispanic whites and those of their country of origin. So Is what we're seeing then therefore all mediated by an immigrant generation effect, a first generation versus a second generation immigrant effect? Well, we have some data sets to study this question. This is very nice data published by Unjung Lee and others at the University of Southern Carolina. This is data based on the California Cancer Registry. And so because the state of California reports both disaggregated race as well as the nativity status of being foreign born or US born, they were able to kind of calculate then the incidence of cancer types by race and by nativity status. And what they found is that there was a partial mediation of the differences in cancer by nativity status. That what that means is that when Asians immigrate to the United States, the second generation, the descendants of the first generation immigrants, do tend to have lower rates of digestive cancer compared to their parents. However, they remain elevated higher than non-Hispanic whites. So what mediates some of these differences, both between first generation and second generation immigrants, but also between second generation immigrants and non-Hispanic whites? So the first general theme I wanted to talk about here are environmental differences, which constitute culture, diet, and environmental pathogens. And so over the next couple of slides, I'm going to take you through a couple of risk factors which hit especially hard, if you will, Asian Americans, and how they may potentially mechanistically give rise to digestive cancers. So one thing that you may not think about as a carcinogen is actually very hot beverages. There are certain cultures in Asia where drinking very hot tea, for example, is common and popular. And you may not think of this as anything particularly dangerous. But the problem with drinking very hot liquids is that it can cause thermal injury to the esophagus. So the picture on the right here demonstrates endoscopic images of acute thermal injury after hot beverage consumption. It can cause ulcerations. And after healing, that kind of chronic inflammation and scarring over long periods of time and repeated is a risk factor for cancer. So drinking very hot beverages has been associated with an increased risk for esophageal squamous cell cancer. That's the type of esophagus cancer that I said is more predominant among Asians. There are certain, regions and pockets in China, for instance, where drinking very hot tea is common, and those areas actually tend to have higher rates of esophagus cancer. This association is so strong that the International Agency for Research on Cancer has actually defined drinking temperatures above 65 centigrades as very hot and has classified this as a probable carcinogen. Another risk factor, which is relatively unique to Asia, as far as I understand, is chewing betel nut. So the fruit of the Arisa palm is the betel nut seen on the right here. And when chewed, I actually haven't tried this before, but I'm told that when chewed, this gives a slightly stimulating, almost nicotinic effect. And this is practiced in certain parts of East Asia. I actually just came from a trip from Taiwan yesterday, came back yesterday, and I know that there in certain parts of Taiwan, chewing betel nuts is still relatively common. And it turns out that this is actually a risk factor for cancer. On the table on the left, this is a very nice case control study, also from Taiwan, looking at risk factors for esophageal squamous cell cancer. And I just wanted to highlight the three big ones here. They call these the ABCs. So A is alcohol. So if you look at the table here, consumption of a smaller amount of alcohol, under 1,200 grams a year, is associated with about a 2-time odd for getting esophageal squamous cell. Consumption of more than 1,200 grams associated with almost a tenfold increase tenfold increase in odds ratio for getting squamous cell cancer. Looking at betel nuts, the Arisa chewing. So if you chew under 500 betel years, I guess that's how they count this, then your odds ratio for getting esophageal squamous cells is about 3.6. If you chew more than 500 betel years, then it's 9. And for a cigarette, if you smoke less than 30 pack years, odds ratio of 1.6. And smoking more than 30 pack years, an odds ratio of 3.2. So for all of these risk factors, there appears to be a dose effect here. So the ABCs, alcohol, bagel nuts, and cigarettes are major risk factors for esophageal cancer among Asians. So alcohol, just to kind of briefly talk more about this, when we think of alcohol, I'm not sure about you, but for me, I don't necessarily think of Asians having very high rates of alcohol use or alcohol abuse. But it turns out, if you look at large-scale epidemiologic data, East Asians have the highest attributable fraction of alcohol-related cancers in the world. Let me rephrase by saying East Asian men have the highest attributable fraction of alcohol-related cancers in the world, higher than Central Europe or Eastern Europe, higher than Western Europe, higher than Africa. So this is a little bit of a surprising figure to me, and I think that has to do with some rather unique predispositions among Asians that we're going to see a little bit later in this talk. So alcohols are associated with cancers of the upper aerodigestive tract, such as the oral cavity, the pharynx, the larynx, the esophagus, as well as cancers of the colon, the rectum, liver, and female breast. Asians also have a very high attributable fraction of cancers due to infectious agents. So outside of sub-Saharan Africa, Asians, including China, India, Japan, and other parts of East Asia have the highest fraction of cancers due to infectious agents. So what are these infectious agents? Probably the most dominant, the largest single one is Helicobacter pylori. Helicobacter pylori, a major risk factor for gastric cancer, followed by human papillomavirus, which is associated with certain head and neck cancers and perhaps squamous cell cancer, esophageal SCC as well, and then hepatitis B and hepatitis C associated with liver cancer. So Asians are at increased risk for infectious mediated cancers. So I wanted to spend a little bit of time here focusing specifically on Helicobacter pylori. This is a topic that I have done some work in. Helicobacter pylori remains a leading environmental cause of cancer death worldwide. So this is the reported prevalence of Helicobacter pylori around the world. And so for the most part, you see a nice tight correlation or association between a country or region's Helicobacter pylori prevalence and their risk and the rate of gastric cancer. However, there are a couple of interesting and notable exceptions, for instance, South Asia, India, as well as parts of Africa. So now I wanted to bring up this theme of multiplicative effect or synergistic effect. So it seems that certain risk factors or certain genetic predispositions can work together to increase your risk for cancer more than just the addition of the risk factors. We call this multiplicative effect in epidemiology. So what's an example of this? So here on the left, this was from a case control study, I think from Korea, where they were looking at risk factors for developing gastric cancer. So we know that H. pylori infection by itself is a risk factor for developing gastric cancer. So if you look here, the odds ratio was about 1.7. And we separately know that eating salty foods is a risk factor for developing gastric cancer. So if you are H. pylori negative and you eat salty foods, your odds ratio of getting gastric cancer is about 1.4. But what if you both have H. pylori infection and you like salty foods? Well, here then in the red box, your odds ratio then jumps up to 10. So there is this multiplicative effect. Somehow that combination of eating a high salt diet and having the Helicobacter pylori infection leads to some synergy that really dramatically increases your risk. And we're going to see that theme again and again for risk factors among Asians. We have some gerbil data or some rodent data to suggest this as well. This is from the figure on the right here. And so here in a rodent model, they infected these rodents with two types of Helicobacter pylori. One was a wild-type Helicobacter pylori, and one was a CAG mutant. So CAG is a virulence protein found in most strains of H. pylori around the world. And so when you look at this figure on the right, oh, and they fed them two types of diet, either a regular diet or a high salt diet. So the uninfected gerbils basically didn't get any stomach inflammation. And the gerbils infected with a CAG mutant H. pylori strain also really didn't get any inflammation. But when the gerbils were infected with the wild type H. pylori, they did develop significant gastric inflammation. But how much gastric inflammation actually was mediated by how much salt they were given. So the gerbils fed a regular diet, developed some inflammation, a mean inflammation score of around 6. But when these gerbils were fed a high salt diet, and were exposed to H. pylori infection, their mean inflammation score was about a 10. So again, this idea of synergistic effect between multiple risk factors. So here now I wanted to briefly turn the talk to the interaction between risk factors and the host, and specifically host genetic factors. So there is this interesting story from Colombia, and so this, the Colombia is in South America, not in Asia, but I think that this is still an informative story here. And so there are these two areas in Colombia. There is the mountainous areas, and then there's the coastal areas. And the people who live in the mountain, the coast, are racially different, and they also have very different rates of stomach cancer. So the coastal areas are the people who live there are predominantly of African origin, whereas the people in the mountains are predominantly of Amerindian origin. And the rate of stomach cancer in the mountainous areas is about 25 times the rate on the coastal areas. It's a really dramatic difference, within the same country, maybe just within 50 miles of each other. So this was a study published in 2014 in PNAS, where they sequenced both the H. pylori, which is the figures on the bottom, as well as the host, and then they derived the origin of the H. pylori and the origin of the host. So you'll see in the coast, the humans in the coast are mostly of African origin, the blue line here. And then the H. pylori from the coast was also mostly of African origin, though there was some European mixed in, as well as just a little bit of East Asian H. pylori. When you go to the mountains, there is predominantly Amerindian origin. But when you look at the H. pylori strains, this is where you see something very interesting. There are certain people with lots of African origin H. pylori in the mountains. And so when they kind of looked at the people who were getting gastric inflammation and gastric cancer, it was exactly these people with a discordance between their host and the H. pylori origin. So it was the humans living in the mountains who were of Amerindian origin who were infected with African strains of H. pylori. And this was a pretty interesting and at the time a groundbreaking study showing that the importance of the host and the host genome and that interaction between host and pathogen was critical in driving inflammation. Here's another example of where the interaction between host and pathogen can make a significant difference in cancer risk. This is a very nice cohort study performed in Japan. This is data from the hospital-based epidemiologic research program from a group of hospitals in Japan. This was published in the New England Journal in 2023. And what they did is they divided the cohort into four groups. So they had the controls. So these were non-carriers who were not infected with H. pylori. Then they looked at carriers. So carriers in this case were those with a germline pathogenic variant in homologous recombination genes. In this case, there were four genes: ATM, BRCA1, BRCA2, and PALB2. And when you look at the bottom two lines there, so if you're not infected with H. pylori, so you're uninfected carrier, so meaning you have one of these homologous recombination genes versus uninfected non-carrier, there really wasn't any significant difference in your lifetime risk for getting gastric cancer. If you were a non-carrier and you were infected with H. pylori, of course, you did have an increased risk, but the highest risk was actually those carriers who were also infected with H. pylori. I have to say this was a very controversial study when it came out because traditionally we think of these as separate processes. We think of the environmentally induced gastric cancers, those are your H. pylori gastric cancers, which go through Correa's cascade of inflammation, damage. And then we think of the genetic causes, the hereditary diffuse gastric cancers, the CDH1 mutations, which we think of as like totally different mechanistically. But I think this was the first to show that there can be some synergy that we don't quite yet understand between the germline variants and the environmental pathogens. And so, I think that this study shows that there's more research to be done, and that the interactions between host and pathogen, or maladaptions between that interaction between host and pathogen may give rise to diseases. So this is another example of a unique risk factor faced by Asians, and the multiplicative effect of risk factor and germline. So this is me. So this was me a couple of years ago, and I'm one of the 40% of Asians who flush when they drink alcohol. They turn red when they drink alcohol. So me on the left, this is normal me, and then me on the right is after 2 shots of tequila me. And so clearly, I am my face is red, but also I was tachycardic and perhaps slightly hypertensive, and just generally uncomfortable. And so what is going on here? So this is mediated through carcinogenic intermediate in alcohol metabolism called acetaldehyde. Normally, what happens is that alcohol is broken down by ADH into acetaldehyde, which is quickly metabolized by ALDH2 into acetate, vinegar, and then you pee it out. But in 8% of the world's population, 40% of Asians, there is a deficiency of point mutation in the ALDH2, which reduces the effectiveness of conversion of acetaldehyde to vinegar by about 90%, 90+%. And so acetaldehyde can build up in the system. And because it's toxic, a poison, it can lead to all these unpleasant side effects. So this is, some people I've heard say, well, turning red is just metabolizing the alcohol or something cute. But it's actually not that cute, because it can lead to esophagus cancer. So this is a squamous cell. Like I said, squamous cells are more common among Asians. So this is an image of an esophagus cancer on the right here. This is a particularly bad-looking one, in a male with flushing and alcohol drinking. The figure on the left is from a case control study, I think from Japan, published in PLOS Medicine about 10 or so years ago. And so they looked at two groups. They had the blue group, which is never flushers. So those are wild type for the ALDH2. And so if you're a non-flusher and you drink alcohol, there is an increased risk of esophageal squamous cell. But it's not as much as if you flush. So the reds are the individuals who turn red who flush when they drink alcohol. And so here the difference is very dramatic. If you drink a low amount of alcohol, or you don't drink alcohol at all, if that's your starting point, versus if you drink a large amount of alcohol, I think in this case it was like 14 drinks a week, your odds ratio of getting esophagus squamous cell was actually 70. It's a huge effect. In fact, the association between alcohol flush and esophageal squamous cell cancer is among the strongest associations between a single risk factor and a cancer ever discovered by science. So for the last one third of this talk, I wanted to talk about how we can harness the knowledge about epidemiology, about risk factors, about host and risk factor interactions into a plausible framework of prevention. And I think there are two concepts I wanted to first talk about here. The first is the idea of variable population risk. So in the general population, you're going to have some group of people who are at moderate risk, and then there are some group of people within that moderate risk population who will be high risk. And so having effective mechanisms to identify these moderate or high risk groups will allow us to really target prevention at those that will need it the most. The second idea is the concept of the tiers of prevention, primary, secondary, or tertiary. So primary prevention refers to reducing exposure to carcinogens. So for instance, smoking cessation or use of sunscreen. So you prevent the carcinogen from taking effect. Secondary prevention refers to mechanisms that interfere with cancer initiation, carcinogenesis, or cancer progression. So, for instance, doing a colonoscopy to remove a colon polyp so that that colon polyp cannot turn into cancer would be an example of secondary prevention. And then tertiary prevention or adjuvant interventions or therapies once cancer has already occurred. So I wanted to bring up the example of liver cancer here, and specifically the risk factor that pertains to Asians, most pertinent to Asians is hepatitis B. Hepatitis B is responsible worldwide for the plurality of liver cancers, about 40% or so of liver cancers. And so what happens with chronic hepatitis B infection is a progressive cascade of damage, inflammation, scarring, and finally cancer. And so the progression rates from hepatitis B to cirrhosis are 5-year progression rates are estimated to be 20%. From compensated cirrhosis to decompensated cirrhosis, about 20%. And from compensated cirrhosis to liver cancer, about 6 to 15%. So the burden of hepatitis B in the United States is very unequally distributed. Overall, about 4% of patients are chronically infected with hepatitis B, higher among men than women. But when you look at it by race, it's 2% among non-Hispanic whites, 10% among blacks, and 21% among Asians. And a lot of this is driven by the foreign born. So among non-US born, the prevalence is 12%, US born is about 2.5%. So there are two ways to look at this. The first is that Asian Americans have 10 times the prevalence of chronic hepatitis B compared to non-Hispanic whites. Or put another way, Asians represent 7% of the population, but nearly 60% of the cases of chronic hepatitis B. So there are very effective strategies to intervene here along every step of the carcinogenic pathway. So at the level of primary prevention, we have effective means to prevent viral transmission, such as antiviral prophylaxis for viremic mothers. Most of the time, hepatitis B is contracted in infancy. We also have, very effective hepatitis B vaccines, and so universal, hepatitis B vaccination has significantly reduced the burden, the prevalence of hepatitis B among younger age cohorts. For secondary prevention, we also have very effective means to reduce viral load, to suppress viral load through antiviral therapy, to reduce the incidence of progression to hepatocellular carcinoma. We also have means to screen for hepatocellular carcinoma, such as through ultrasound screening. So we have very good mechanisms to interrupt cancer, both through primary prevention and secondary prevention. However, despite this, there remains major public gaps in knowledge. And sadly, in the United States, an estimated 80% of chronic hepatitis B carriers remain undiagnosed. So this is a major opportunity here for public health intervention. Another major opportunity, in my opinion, is gastric cancer screening. So this is data looking at three countries: South Korea, Japan, and the United States. And here we're looking at the percentage of cancers that were diagnosed at a localized stage, a regional stage, or a distant stage. So localized is the best. You want early cancer diagnosis. Distant is the worst because that means it's already spread. And so when you compare South Korea, Japan, and the United States, in South Korea and Japan, about half of all cancers are caught early. By comparison, in the United States, only 28% of cancers are caught early. And when you look at overall survival from cancers, in Korea, 67% survive a diagnosis of gastric cancer. In Japan, 65% survive a diagnosis of gastric cancer. But in the United States, only a third survive a diagnosis of gastric cancer. I would challenge you to name any other cancer where America performs so poorly relative to our industrialized peers. Here's some temporal ecological data also suggesting that screening may have an effect. Oh, so I forgot to say why. So what is the screening programs in South Korea and Japan? So South Korea and Japan both have national screening programs, either an upper endoscopy or X-ray, barium X-ray every 2 years for the entire population. So this is ecological data from South Korea. They began this biennial endoscopic screening program in 2001, and the green line is data from the South Korean National Cancer Center, and you can see that the percentage of cancers that were caught at an early stage went from about 40% up to 73% in 2016. If you extend this line out to 2021, 2022, it's actually now about 80+%. By comparison, the red line in the United States, what percentage are being caught at a localized stage? This is data from SEER, and there really has been no change over time because there's no organized screening program, so there would be no change over time. There have been certain simulation-based models, Markov models, which have suggested that performing a one-time upper endoscopy at the time of your first colonoscopy, all Americans should be screened for colon cancer beginning at the age of 45. So what if we added on an upper endoscopy and EGD at that time, at the age of 45? Is that a cost-effective way to screen the U.S. population? And this modeling study by Shalja Shah and others from San Diego did demonstrate that for Asians, Hispanics, and non-Hispanic Blacks, this was a cost-effective strategy. They could save a quality-adjusted life here for under $100,000, which is by some measures a marker of cost efficiency. So in Asians, gastric cancer screening might be cost-effective. So this all kind of comes down to the theme of how do we optimize screening value to certain populations. And so when you screen a population for cancer, we need to look at two things. The first is the benefits of the screening. So the benefits come from earlier diagnosis, reductions in morbidity, reductions in mortality. But when we screen too much, we also increase costs, the economic costs of the screen, but also psychological costs and also harm of screening. So doing endoscopy, for instance, there's a small risk of adverse events, sedation event, anesthetic event from the procedures. And so the net benefit of a screening program, or the value of a screening program, is the overall benefits of the early cancer detection minus the harms and costs of that screen, which increase with screening intensity. So we want to be kind of right in the middle here in that high value column where the benefits are high, but the harms and costs are still low. And that provides optimal value for a cancer screening program. So hopefully after this talk, by understanding cancer burden, by understanding the unique risk factors that Asians face, and by understanding the prevention strategies that are available to us, we can optimize screening value for Asian populations. So I think the key points from this talk are that Asian populations are at heightened risk for multiple digestive cancers. This enhanced risk is mediated through a combination of cultural, dietary, and environmental risk factors. Environmental risk factors may interact with unique genetic predispositions in Asian populations to further enhance risk. And knowledge of risk factors and methods of prevention, both primary and secondary, may reduce digestive cancer morbidity and mortality in Asian populations. Thank you all for your kind attention, and I look forward to your questions.